Okay, so this is a slightly different talk in a way, using genetic and genomic diagnostics to create control or therapies that work. So I will show another aspect of the topic of this morning. We've recently come up with, let's say, a model of the pathogenesis of CLL, chronic lymphocytic leukemia, the most frequent leukemia in the Western world, based on an expanded and well-annotated cohort of CLL patients that we have kept in our clinical trial database, where we have over 7,000 fully annotated CLL patients. And I show this also to bring one aspect into the discussion, that is the particular importance of the good and full clinical annotation of samples, especially if you want to follow clonal evolution, or if you wish to study the effect of certain treatment regimens or different diagnostic subgroups, then this becomes extremely important and has allowed us to formulate a couple of hypotheses. So by doing this and using this genomic information, you can come up with a model of pathogenesis where you identify pathways along which mutations occur and that are probably essential to form the malignant clone. In this publication, although the genome of CLL has been described a couple of years ago, but when you expand those clones into more cases that are well annotated, you have new discoveries. And what you see in purple are all the novel genes along some pathways, and I don't explain them all to you, that have been discovered by just adding more cases with good annotations, and then describe that along certain aberrations there is more than just only one mutation or aberration. So essential pathways are the B-cell receptor signaling, although interestingly not at the kinases that we are usually targeting, and I come back to this. Wnt signaling, Notch signaling. Then of utmost importance for a poor prognosis is all pathways around DNA damage control, chromatin modification, and RNA processing. This then allows you to formulate a sequence of clonal events in this disease, where in this probably unique setting, we have large loss of chromosomal material in CLL, with deletions of large parts of chromosomes at chromosome 13, 11, and trisomy 12, so in addition. And that's actually forming usually the founder lesion, if you wish, in this disease. And subsequent lesions are coming later, some of them, including P53, usually defining patients at very, very poor prognosis. If you have the addition of ATM deletions also, that is meant to bring additional prognostic value, unfavorable value, of course. Now, with this information, we can now go back into clinical material, clinical trials, and see whether we can draw any conclusions. And one of the trials that has formed a lot of this knowledge is the CLL-8 protocol that we did years ago, and that basically brought a new standard treatment at that time, namely FCR, fludarabine, cyclophosphamide, rituximab, into CLL. This is the curve, they updated in 2012, showing for the very first time that by choosing the right first-line therapy for CLL, you can prolong survival. Until then, we believed that this is a recurrent disease, you can't cure it, you can't control it, so you can also use your, let's say, best treatment last and keep it until you have nothing else to offer. This study actually showed the opposite. When we go into a deeper analysis, and now I come to the genetic information, you can see that the response, the efficacy, and more importantly, the overall survival varies a lot depending on certain genetic lesions. And the first that we studied since the pivotal work of Hartmut Döhner and his group were the chromosomal aberrations. So trisomy 12, deletion 13, 11q, and unknown chromosomal aberrations are forming a group that has a fairly good prognosis, while one subset of patients that carries deletion 17Ps, and I could add here also P53 mutations, usually has a very, very poor prognosis with chemoimmunotherapy. That does not change the outcome. On the other hand, if you use one subset, and I show you this one here, just depending on the antigen receptor mutational status, you have to remember that CLL is a B-cell disease. They have an immunoglobulin at the surface, and they are mutated or unmutated, come in two forms. And if you look at the mutated version, which is usually having a better prognosis, you can see that they benefit from the treatment the most. And there is even a plateau type of curve here that might look like a cure, or at least a very, very good prognosis in this disease. And we went on then after this and looked into a combination of all these factors, which is mutation of IGVH, and here I take only the mutational status of mutated patients so that they have a good prognosis in combination with chromosomal aberrations. You can see that there are some groups that don't relapse at all, some of them now for 14 years or so. They have a very, very good prognosis, and you could say that a combination of trisomy 12 or 13q deletion or 11q deletion with mutational status of a mutated form, so the good prognosis, is giving you a subgroup of patients, a relevant subgroup. This is approximately 15 to 20% of our patients that might eventually be in long-term remission or cured. It's a discussion by the addition of an antibody plus chemotherapy. So this is selection by good prognosis. Now, in CLL, there is, like maybe in no other disease, a development of targeted agents that are targeting this antigen receptor, the one that is mutated in CLL. And you can see that the antigen receptor, or the B-cell receptor, is basically signaling through kinases, and this complex diagram actually highlights simply how many of the inhibitors are developed, and in the clinics are currently ibrutinib and idelalisib, and I will focus a little bit on those. And venetoclax inhibiting BCL2 is close to be approved for CLL. To simplify this complicated cartoon a little bit, I use a didactic diagram, if you wish, where you can say, well, CLL can be understood as a balance or imbalance of life and death signals. It's a very, very high oversimplification, but basically you have proliferative signals that are running through the B-cell receptor, as I said before, or any other microenvironmental receptor. I chose here the toll-like receptor that is signaling through MyD88, actually mutated in some cases, and that activates NF-kappa B and other transcription factors and is probably supporting cell proliferation or survival of B cells. On the other hand, B cells, when they are used, need to die. Actually, that's one of the most important features, that they need to be cleaned when they are not needed anymore. And as you know, molecules or proteins such as BTL2 are inhibiting programmed cell death, and they themselves need to be inhibited to actually allow programmed cell death. One of the most important events in CLL is mutations in the DNA damage response. So this highlighting very poor prognosis, P53 alterations. P53 is on chromosome 17. Chromosome 17 actually frequently deleted. And you can imagine that in these patients, the DNA damage response is totally altered, and therefore these patients have a very, very poor prognosis, and they do not respond to chemotherapy because you need P53 to exert the action of chemotherapy. Now, I show you this because we now have drugs on ibrutinib and idelalisib that are inhibiting some of these pathways here, and we also have drugs such as ABT199 or venetoclax that are able to impair the BCL2 function in CLL. And CLL is a disease that has a very, very high expression of BCL2 in almost all cases. And thereby you shift the balance, and that's actually the mechanism, the proposed idea, although it's a very, very strong simplification how this works. Now, this works clinically, and I quickly show you examples how these agents are working in CLL and how we are going to use them in the future. So the first to be approved, and the first actually now in the clinical use, is ibrutinib, and shows one feature that is very, very unique to this class of agents, that you have a very, very slow onset of response, probably because there's a compartment shift, probably because the B-cell receptor targeting is not the only mechanism, and the interaction with the microenvironment is of utmost importance. But when you study ibrutinib in the long run, usually there is a long-lasting remission for many patients, including patients with unfavorable prognosis. So this is the cases where I showed you before how poor the prognosis can be, p53 mutations, or deletion 17p, which is very similar. And you can see that with ibrutinib, this progression-free survival is fairly good. It's actually better than all the survival curves in this population of patients with chemoimmunotherapy. The next agent is idelalisib targeting PI3 kinase. This came out a year later. And basically, I show you data from one trial that was studying idelalisib in combination with rituximab versus rituximab plus placebo, and then there is an extension. So all patients could get the inhibitor, but some of them later if they didn't respond in the placebo phase. And what you can see here again is that there is a strong difference, not only in progression-free survival, but a very strong effect. This is a high-risk patient population. Lots of them had p53 mutations, and you see a strong survival difference, despite the fact that these patients could get idelalisib, so the inhibitor, later. And finally, the last agent or class of agents, but the one that is most advanced in the clinical setting right now, is venetoclax. So venetoclax basically acting as a BH3 mimetic here, and that is leading to a dysfunction of BCL2, which is then basically allowing to undergo apoptosis. This agent is probably one of the most active agents that we've ever had for CLL. This is an updated study combining ABT199 plus an antibody rituximab, recently presented at a meeting at EHA. And you can see here from these waterfall plots that this is basically a waterfall box where most patients have complete remissions with this combination here in the compartment of the bone marrow. And also the majority has very, very good remissions from the lymph nodes. So very, very potent agents. This is in pre-treated patients. If you look at the responses, 84% of the patients do respond, and half of them have complete remissions, which is twice as much as with former chemoimmunotherapy. So you have three agents or classes of agents, if you wish. And the key question is now, how are we going to use those agents in the future? Basically, we need to combine them with antibodies. And one of the strongest and most potent antibodies, so an improvement over rituximab, the anti-CD20 antibody, came into the game recently. This is having more efficient killing mechanisms, enhanced ADCC, and direct cell killing, which is much stronger in CLL as compared with rituximab. So here you can see that this antibody is actually clearing the blood from leukemia within hours, in most patients within days. And that's the most potent antibody for this disease. Therefore, we could show in a randomized comparison that G101 compared to rituximab is prolonging the progression-free survival when combined with a mild chemotherapy. And this is also allowing to improve survival, even in elderly patients with comorbidity. So now we have anti-CD20 antibodies, novel ones that are extremely potent, novel agents, including some that induce complete remissions even without any other therapy. And so how are we going to use those novel agents? I show you first, since it's the topic of this morning, how this is translated into the clinics, and that has developed over the last 12 to 18 months. So CLL or leukemia therapy in this disease is fairly personalized. Very often patients present with an inactive stage, and they are not treated at all except in clinical trials. If the disease becomes symptomatic, then we look first at the fitness, and the fitness is actually allowing us to give chemotherapy. And I showed you that some of these patients are extremely well treated and respond extremely well with chemotherapy. We may actually go to even more sophisticated approach by saying, well, they need to be negative for dysfunction of p53 and to have a mutation or hypermutated IGVH, but that's not standard yet. It is probably going to come. So for some patients still benefit extremely from standard chemoimmunotherapy. For the rest, we now, for patients that have a lesion 17p in particular, we now moving more and more to kinase inhibitors. For elderly patients that have a reduced fitness, you cannot apply these intensive chemoimmunotherapies, and therefore milder chemoimmunotherapies with chlorambucil and the novel antibody are applied. For patients having a deletion 17p, this treatment is recommended. So we have a split or decision, a stratification, if you wish, according to several molecular parameters and fitness that allows you to give the right treatment to the right patient. In the future, and the future is actually starting now, we will combine these agents. So we've developed this approach by simply combining the best principles into one approach, which is allowing to tailor, target, and to totally eradicate the disease. So we have a debulking step, induction therapy. Debulking can be done with chemotherapy, but is only needed for patients with a very, very high tumor load. Needed because some of these agents are so potent that we have tumor lysis syndrome, and we wish to avoid that phenomenon by the pre-treatment. And then we do the proper therapy, by just using kinase inhibitors and antibodies for a short duration, determine the remaining disease, minimal residual disease, and continue with targeted agents, 1 or 2, for the time needed to achieve minimal residual disease negative status. So we are doing a series of trials. I show you only 4 that combine these agents here, ibrutinib, ABT109, CAL101, with different antibodies and are called Big Bag BCG Bio. So recruiting extremely fast. Within 5 months, we have finished this one, 5 months this one, and the 2 other trials have been opened later and are recruiting extremely fast. I show you one example why this is so attractive. So we do the debulking step here. This is one case, a 70-year-old patient that has a very complex karyotype and p53 aberration. So she has really a very, very poor prognosis. Treated here so that we could debulk from 300,000 leukocytes, so very high tumor load. She had bulky lymph nodes. It's going down to values around 60,000. At this time, usually chemotherapy doesn't work anymore because she's refractory due to the p53 mutation. So we go in with obinutuzumab according to the protocol, and within days, she's totally cleaned off leukemic cells. After this, we start with the kinase inhibitor. We can shift leukemic cells from the lymph node and marrow compartment, but they get hit immediately by the subsequent courses of immunotherapy or by antibody, as shown here, and then go down. During this entire time, and that's now continuing until October, the patient had basically no side effects from the therapy, and most patients actually don't. They don't actually feel that they have any therapy, just the leukemia goes away. With the remaining activity in this in our German CLL study group, we are now systematically going away from chemoimmunotherapy to combinations, even triple combinations of these agents, ABT109 plus ibrutinib plus G101, so systematically going from a standard step by step to a probably new standard using only non-chemotherapeutic agents. The same is true for the unfit patients, and you can realize that here the treatments become very similar because the toxicity is so low that you probably can give it to all patients quite similarly. The toxicity of these agents, once you overcome the initial phase, is surprisingly low. So I will finish with the following statement. We can see in CLL the emergence of targeted agents with extremely high activity against BCL2, against kinases, and we have more potent anti-CD20 antibodies. All new agents, all published over the last 3-4 years. The current treatment strategies that we have designed are aiming to combine these best agents. We only pick the best in the basket to achieve MRD negative disease, even in high-risk cases. And we already treat all high-risk cases with those agents because chemotherapy doesn't work anymore in the p53 such that it does not work. And with this approach, the clear goal now is to make CLL eventually the first cancer that can be controlled by a combination of non-chemotherapeutic agents. You remember CML? If you wish, the sister leukemia is controlled by imatinib and or Glivec, and it is very likely that many patients with CLL may be controlled in a similar way by using combinations of highly potent kinase and BCL2 inhibitors. And there we have actually, the question is, can we now target this? And that will probably be the next development step by using genetic information and to see to which inhibitors some patient subgroups respond the best. Thank you very much for your attention.
Thank you, Michael, for a fantastic story. Questions? If I may start with one, conceptually, will it eventually be possible to remove the malignant clone, or is it going to be a lifelong treatment?
So what we are trying to design the interesting thing is two of these inhibitors have been developed by companies that have generated antiviral agents, and they have actually knowledge how to combine agents into one principle that allows you to eradicate a virus disease. Now, discussing with them brought us the idea that we can follow the clone actually beyond MRD negativity and just estimate how long you need to treat until you have until you may eventually eradicate the clone. And that's exactly what we are going to do. So the combination trial series, where I showed you back, big, and so on, will now be expanded into a phase where we continue to follow those patients and see how fast the clone goes down, and then eventually go to the point where we don't have any clone, or we expect to no longer see any clone anymore. And that's the next fundamental step. So while some investigators believe that this could be a lifelong treatment, I don't think that this is a good thing to do because it's too costly. And our attempt is simply to have terminated treatments with the optimal combinations and to achieve, eradication of the malignant clone if possible.
Do you see the potential for anti-clone immunity of some sort?
Yes, that's the next big question is, can we incorporate immunotherapy somehow? That will be the next step, although the current agents are so potent that we think it might no longer be needed eventually. So that's actually the only counter argument. But we will test checkpoint inhibitors, we will have CARs, so we will have additional modalities eventually for high-risk patients.
The curse of the good deed.
Yeah.
Further questions? You have one?
Yeah, I mean, you mentioned cost just then. I was going to ask you
the
cost implications, though, of long-term treatment with these type of therapies.
Yes. So that's why we are aiming for...
Not so NICE would pay for all these things.
Yeah, well, so that I have a clear opinion about this. I think the NICE is one thing, but we are physicians and researchers. We have to take care of the disease and eventually try to cure it. Now, in 15 years from now, when the patents are expired, you will have small molecules, small chemicals, and the cost of goods are fairly low. And probably then you will be able to treat CLL for the price of, I wouldn't say aspirin, but it's not too far from that. So from a historical perspective, I would say this is not a long-term impediment for developing these diseases. And it's only to overcome the time of patent protection where these drugs are unfortunately very expensive, and I would say sometimes too expensive.
Yes. Yeah.
But, just for the sake of this argument to stop research on CLL and say, well, it's all going to be too costly, I think that's unethical.
Yeah, I had a similar temper tantrum yesterday in the discussion that I just think we shouldn't be censoring in our heads what we do by the price that it might cost in the future.
Well, and hopefully when you get a therapy like this and the price is very high, it actually changes the balance of the cost.
Oh, it will, and also...
And that can change prices.
Yes, absolutely. and I'm totally aware that a lifelong treatment with agents like this is not a good option, because that's going to be costly. If you terminate it, and we already think about doing it in 1 year, that might eventually help also to control costs.